Thank you so much, Dr. Ghavami and Dr. Nazarian, for joining us. It's really an honor to be able to talk to you about some of the latest minimally invasive radiofrequency technology.
Thanks so much.
Thank you.
So what we'd like to do is go through, some of the different technology that we use and discuss kind of the treatment gap. And, before we get started, who do you guys like to use this type of radiofrequency technology on? What's your target population?
Sheila, go ahead.
Yeah, for me, it's kind of the person who has minimal to moderate amount of laxity. Maybe, you wouldn't say they're ready for a facelift yet, or they have a little bit of a pre-jowl happening, a little bit of a prominent fold in here, maybe, up here, right above I call it a sausage, right above the laugh line. So, or the minimal to moderate amount of laxity in the eyelids. It's really just been a great addition to my armamentarium when it's someone that I necessarily would have sent home 5 years ago for a facelift or for eyelids or for whatever, and told them, you're not ready, come back in a little while. This has sort of allowed me to take volume away and tighten the skin when it's necessary to, and just not try to camouflage everything with fillers to hold them over.
So for me, the way I look at this is it's kind of the spectrum continuum of where the soft tissue skin and the ligamentous attachments to the deep muscle and bony framework has started to separate. And usually, as we know this from deflation. So in that grade of deflation degree and magnitude, you have a certain period where you can make the tissue taut and skin taut by adding fillers or fat grafting. And then in addition to, or instead of, in certain patients don't necessarily want or need filling for volume, it gives you just that little bit of pull and tightening to that soft tissue where it has an effect on overall contour and makes the whole face globally, comprehensively look tight. Because if you're at the point, like Sheila said, where that soft tissue envelope of your facial skeleton and soft tissue fat pockets and fat compartments have deflated and it's separate enough where muscles here and skin is gliding over it, then you can't get enough tightening for the patient to be happy. So it's really a judgment call, I think, for each provider to know when is exactly that threshold where I actually need to anatomically rearrange and reposition the tissue, as opposed to getting a little bit of tightening to augment that, because it's still somewhat attached to the framework, muscle, and bone.
Yeah,
Right,
and I would add to that too, that, these people that you perform the radiofrequency treatments on should have some fat, that you want to melt. If a patient is completely skeletonized, then a surgical procedure like a facelift might be more appropriate.
Or Morpheus.
Yeah, or Morpheus. I mean, I think, we're very good at removing fat through either, cryolipolysis or liposuction or Kybella, but skin tightening has really kind of been the holy grail. And so this is really the treatment gap, and the question is, how do we bridge it? And you guys have a unique population in Beverly Hills. I think patients are extremely savvy, and they have a lot of resources available. But I think, globally speaking, patients just want the latest technology and minimal downtime. Do you find that patients, do you have patients that would prefer not to have surgery and do this technology, or do you have more patients that just want to go kind of the full way if they had the option?
Ash?
Well, I provide all different types of surgical facial rejuvenation in addition to other things I do. So I have 5 different facelifts up my sleeve thanks to my training. So they know that going to me, I'll provide them exactly different options. I will always, for the most part, any surgery, give people 2 options, sometimes 3. I don't want to confuse them, but this is definitely an option with or without surgery. It can be an adjunct to surgery. We can talk about body later, but with liposuction, if you want a little bit of skin tightening in certain areas regionally, it really complements your results. So you can go ahead and do all the skin tightening with radiofrequency, then liposuction. In the face, fat reduction is not as accurate. Maybe buccal fat pad tailoring is, but for the most part, you can't really predictably liposuction or remove fat from the face unless you're surgically taking it away with scissors and completely re-sculpting the face by elevating the overlying tissue and getting at that SMAS and subcutaneous layer to sculpt that away. So I prefer not to use this for fat melting technology. If I'm removing fat, I want it to be either directly precise with a cannula or with a scissor. I'm very surgical, kind of a surgical strike. So I think if you give people two options, you're able to do the other option, or if you're not, you're able to refer them to someone who's a colleague that you trust that can give them the surgical option. Then you just have to be honest with your patients. Most people in LA will try to choose less invasive options or quicker downtime, but I always tell people there's no shortcuts. If you are at the point where you've crossed a threshold and you do need surgical intervention, I'm going to let you know that, and this may not do enough for you to be happy, even if the downtime's low.
I tend to agree on a lot of points, but I do use this technology as an adjunct to fat reduction for sure, especially when it comes to areas like the jowl, above the laugh line. I will use it in addition to facial liposuction in order to decrease and take away volume. But I always tell the patients, if I just went in and took down the volume of your jowl, you could have skin laxity. So what I do is I go in first with lipo. I know you guys don't teach it this way, but I do go in with micro lipo. First, I remove about 70% of the fat that I would want to remove. Then I go in with the radiofrequency technology under the skin to melt the rest and tighten those ligaments and tighten the skin for the rest of the way. So that has given me fantastic results. I'm super happy with it. I mean, sometimes it's almost like, a facelift result. It's crazy, and it just depends on how much collagen that person builds, how young they are, their genetics, and also the technique.
Right, I agree. I think the patient selection with radiofrequency specifically is really key, because if you apply it to the right patient, and I agree with what you said, the hardest patient to treat is just one with only lax skin. Some fat actually is helpful. And I just wanted to go through a little bit of the science of radiofrequency. As you guys know, radiofrequency has existed in medicine for almost 100 years. It's permeated kind of every field of medicine, from cardiac ablation to orthopedic tightening, even oncologic procedures. And basically what it is just an electromagnetic current that's traveling through tissue. And the good thing about it is it's non-specific, so you can use it on all different patients, all different skin types. And just as you guys alluded to, that we have these fibroseptal networks here, and the fibroseptal networks have high resistance, so they actually generate more heat to allow for skin tightening. And so, what percent would you guys say you may see with this kind of technology as far as soft tissue contraction goes?
I usually quote them about 30%.
Mm-hmm.
I would agree with that, especially, I mean, the one that goes under the skin. If you're using an AccuTite device or FaceTite, BodyTite, probably BodyTite on the, it depends if it's a large surface area. If we're talking face, 30%. In the other areas, I tend to really under-promise and quote 15, 20, and say they might have to stack treatments in the future.
Yeah, we usually say about 30%. And the nice thing I think about this technology, just from a psychological standpoint, is that I think if you do a facelift, or you do a big, not a big, but if you do a true traditional excisional operation, there's recovery, there's cost, and as those things increase, the patient's expectations also increasing. The nice thing about this is it's less of a cost, it's less of a recovery, and I think as long as you pick the right patient, their expectations are a little more reasonable. So a lot of people are happy, I think, with 20, 30, 40% improvement and not having the downtime.
The other thing, speaking of psychologically, is I always tell them you're going to get an immediate gratification from the fat reduction. And I tell them you're going to see a lot of skin tightening over the first 3 months. But in my practice, and I don't know about you guys, but I have seen some patients where really when they hit 10 months is when I'm seeing, some significant skin tightening. So I tell them the skin tightening occurs over a year, but you'll get immediate gratification psychologically from the fat reduction.
Yeah, it's hard to judge for me, because I always do either micro lipo or direct excision or some kind of removal that's volumetrically based, visually based immediately for me. And my endpoints are reached. It's hard for me to say, in addition to that, how much reduction did I get, or how much is it just contracture and shifting some of those fat cells and killing a few off that I didn't suction off that are shrinking too. So it's really hard to say how much is from radio frequency unless you don't do any microlipo or any reduction, you're only doing this, then you can probably judge it, because usually the contractor of 30% is not going to compensate for volume reduction unless the patient lost weight too at the same time post-intervention.
Right. Yeah, it's true. Sometimes when you're doing, liposuction with this, it's hard to know what's attributed to what. But, there are patients where you do a lot of liposuction and you don't do radiofrequency. Sometimes you worry about as far as having too much skin laxity. I just wanted to go through, for those who may not be as familiar, these are the technologies that we use. So this is all bipolar radiofrequency technology. Here on the left side, this is the Morpheus device, and I'm curious to see how you guys like the results from this. But the energy is moving, not all radiofrequency microneedling is created equally, and many of the other energy is in between the tips of the needles, and that really limits volumetric heating and contraction and result. So in this particular device, this is patented where you have the energy moving from the tip of the needle. There's 24 silicone-coated tips to the faceplate, so you're really traversing the skin envelope. And then, as we talked about, this is the AccuTite, FaceTite, BodyTite, which are bipolar, so it's moving from the internal cannula to the external. Do you guys have you guys used the Morpheus a lot, and do you like it?
I like it. I've been using it a lot in conjunction with the other technologies. So I know InMode had, coined that embrace RF because you're embracing the skin from underneath and from on top. So what we'll do, especially around the thighs for thigh laxity or arm laxity, what we'll do is we'll go in with BodyTite, and then we'll do 3 treatments, one immediately right after the BodyTite's been performed, and then 2 more treatments 3 to 4 weeks apart in order to sorry, my dog, in order to get even more tightening and get rid of some of that crepiness that's superficial.
Mm-hmm.
Yeah, I do like Morpheus. I do think it's not as powerful without the other, but you'll probably have to do several sessions, and it probably is a little more effective on patients with less distance between their overlying skin and the ligamentous deeper structure. So in someone who's kind of heavy-faced, has a lot of soft tissue, it probably won't be as powerful without the other and as an adjunct.
Right. Yeah, I agree. I mean, just like everything else, the more invasive, the more of a result typically. So the BodyTite, FaceTite, and AccuTite definitely tighten those fibroseptal networks very efficiently. And I usually tell patients, the Morpheus will add 5–10%, and in addition to that, it gives you some resurfacing just from the surface injuries, so it's useful. This is a nice cross section actually showing how the energy moves from the internal cannula to the external. And how do you guys feel in terms of the safety of the device?
I've been really happy with it. It does shut off if you, surge and it's getting too hot. One tip that I would give to people is if you're doing someplace that's superficial like the neck, when you go in, pull back a teeny bit and then start delivering the heat so you don't get that tip pushing against the skin. Even if you do that, nothing happens, it goes away, but it does leave a little white dot while you're doing the procedure, so it can be a little, nerve-wracking. So what I do now is I'll go in, pull back a little bit, then deliver the heat. Go in, pull back, deliver the heat.
I think the key is really being very overly extensive with your pre-tunneling, if you will, releasing the tissue, because especially someone, and in Los Angeles, Sheila can attest to this, it's rare that I get a virginal situation. Someone's already had, mesotherapy, they've had that Kybella, which I completely disagree with, or they've had liposuction or something, and there's or previous, radiofrequency. So if you don't release the tissue enough, that's really going to cause you to kind of catch ligaments and go up a little bit misguided to superficial or somewhere you don't want to be, or especially in the jowls, where all of a sudden you have all the mandibular ligaments here holding the jowl boundaries together, and you're trying to go past that. So it's important to really release the tissue from the underlying anatomy so you can really glide easily in and out. No matter what direction you want to go, you're kind of free. And if you're hesitant, I'll take it out, go release with a 3mm cannula, a power assisted one that's vibrating, and kind of swipe just like I do when I do any type of liposuction case so that I have an even surface. Then I'll go back in with the InMode device.
Yeah, I agree with all that. I think staying deep is really important and avoiding any end hits. as well as pre-tunneling. So the nice thing about this technology is, just like I think Sheila mentioned it, if you have a temperature surge, it'll shut off, and it has very tight control of internal external temperature. Now, just in terms of facial aging, I know both of you do a lot of facial rejuvenation. In terms of how you treat these patients, do you typically do it under general anesthesia, sedation, local? What's your preferred kind of method?
I do it under local anesthesia in the office in the procedure room mostly, unless I'm doing it in conjunction with another surgical procedure that requires them to be asleep.
Mm-hmm.
For facial, local works, except for jawline, neck, I really like to be extensive. I mean, I'll go all the way down to, the clavicle if I have to, so, and in general, if someone's getting all that done to their neck, they're getting neck lipo, they're getting some other lipo done at the same time. It's rare that I'll go in and just do neck lipo, but what I love about this for face is in conjunction with slight buccal fat pad removal, facial fat transfer to the malar. So what you're doing is tightening the malar area cephalad and kind of getting that tightening there by adding fat there. Then you can treat the nasolabial fold, deflate the buccal fat pad just enough to get a nice submalar contouring hollow. And then you can treat the jowls and the neck at the same time. So something like that, if you're going to so many different areas, which I usually do, it's rare that I isolate just the neck. I'll end up doing like a light max sedation, IV sedation, so they're kind of snoring and I don't have to worry about every needle I have to. And I'm good about blocking the whole face, but I just want them comfortable, so I'm not, especially if you are going a little deeper in some of those areas near the bone, they'll feel that if they're not very well anesthetized under local. So it's for me, it's kind of the degree of multiple areas I'm doing, and in face usually I'm doing several. And if I'm just doing mostly the neck and they're getting other things done, they're going to be asleep anyway under general. And those are always the best, although you don't have any feedback. You don't have to really trust the beeps of the machine and your thermal, your numbers that you're looking at.
Right. So for same for me. So I like, if you're looking at this photo here, as we age, we know that the lower third of the face is really the area where we get laxity, and maybe the upper third is more of a volume reduction. So we do combination treatments a lot, where we're filling the fat pads, the deep malar fat pads specifically, nasolabial fat pads, and then trying to remodel the jowl submental area with radiofrequency. And those beeps that Ash was alluding to are safety beeps. So you basically set the device to an internal and external temperature of your choosing. For us, it's usually 68 internal, 38 external. And as the device approaches that temperature, the beeps will change. So you don't even have to look at it. It kind of tells you where you're at. So this is an example of some of our settings here. For us, it's usually 38, 68. As far as safety goes, really the marginal mandibular is the main thing when looking at facial nerves and treating with radiofrequency. And I know you guys both have these images of these near infrared images of heat sensing. It's just kind of nice to have. You can put it on your iPhone.
So I have face typed.
So, just to what Sheila was saying before, I think patients that have fat, like this case is a radiofrequency assisted lipo case, are really, I think, in many ways ideal. And just like Ash was saying as well, removing the fat with the cannula, is the best way to do this, and then tightening the skin on top. Do you guys typically deal with patients like this? Or are they patients with a lot less fat, or is it pretty much more minimal patients in terms of skin laxity?
We don't have these patients in LA. I'm just
Yeah.
kidding. No, we have all types in LA. We have all types in LA, but somebody like this, honestly, I would offer him this. I would offer him extensive liposuction, but someone like this, I'd want to do something with the platysma, even if it's just a posterior neck lift and they're not ready to do a full high SMAS face neck combo. I'd want to at least get a little posterior platysmal tunnel and attach that to the mastoid and do a little bit of a corset and get some of the subplatysmal fat. And usually I can anatomically explain why to patients, and most will understand. But you can get a visually good result. It's just you can get really almost hit a home run if you do it the other way. So that on this particular patient, that would be my choice, is to try to recommend she does that. And I've done those under light sedation, so you don't have to go fully asleep to do a platysmoplasty and a platysmal window to the mastoid at the same time.
I would actually offer these patients, you know, I kind of get a feel for what their mindset is. Some of them come in and they're like, you know what, I don't want anything surgical. And if I feel really strongly about it, I'll convince them, or I'll just say, you know what, I don't think I can get a home run without surgery. But sometimes, you know, I'll offer both and just say, you know what, with surgery, I can achieve this. And with, you know, the InMode technology, I can achieve this. This is your downtime here, very similar downtime here. So, and then I kind of let them choose as long as their, you know, expectations are clearly set. The other thing too that I've been speaking to patients and I would love your opinion on is I always tell them if they start with the InMode technology, they're actually building a lot of collagen. You know, and so if we do this and 2 years from now, or 3 years from now, or 10, whatever, they say, you know what, now I'm ready for a surgical facelift or a neck lift. I tell them you haven't burned any bridges. If anything, we've just stuck a whole ton of collagen, you know, and improve the quality of your skin. And I know some people will actually use the InMode technology as a maintenance after a facelift. So I always tell them if we do this first, you haven't burned any bridges, we can always do the facelift later. And a lot of people actually like that option.
Right. Actually, it's funny you say that because a lot of the kind of more traditional surgeons sometimes knock technology. You know, I think technology and aesthetics is complicated because a lot of it hasn't worked and it kind of impacts how everybody views technology that does work sometimes. And as far as radiofrequency, you're absolutely right. We actually did a study that's being published in the Journal of Plastic and Reconstructive Surgery on looking at indocyanine green evaluation of perfusion and lymphatic flow after radiofrequency. And actually, animal studies have shown that the heat from radiofrequency causes neoangiogenesis, lymphatic reorganization, and neocollagenesis. So it actually, I agree with you, it puts you actually in a better position for a surgery down the road. It's a rejuvenating technique.
That's good to know because I always intuitively thought if you're heating the lymphatics, you're collapsing them and scarring them down, that you're going to have more swelling if you were to do surgical intervention within 3 months. So it sounds like you get a little bit of a delay phenomena. That's amazing.
Yeah, you actually get increased VEGF, which causes new flow. And actually, we've used this for treatments of areas like malar edema. The fractional radiofrequency, the Morpheus, you can actually use, you know, sometimes patients get swelling after filler around the eye. And you can actually use it to help treat that as well, yeah. So this is the Accutite device. You know, the nice thing for us about this is it's kind of more on the spectrum of fillers as far as the size of it. It fits through an 18-gauge cannula. What areas do you guys typically treat with Accutite?
I've done upper and lower eyelids, you know, festoons, the sausage above the laugh line, that little, you know, extra fullness. I've done jowls and, you know, sometimes they'll be young, no jowls yet, but they'll have a little bump right here, and especially in Caucasian women. And also the neck, I've gone ahead. So if I'm treating all those areas and I want to hit the neck, I'm not going to open up the face tight and waste the you know, tip. So I'll just use the Accutite in the neck as well. I know some people have used it for vaginal rejuvenation as well, but I haven't used it there yet.
I agree with Sheila. I've done it for all those areas. It's great for the lower eyelids. Even in a young patient who's, you know, all her life, they've had that anatomical, you know, lower lid cheek disjunction, and it's not due to aging. You can just really get, I don't know if it gets the orbital septum or what it does, but it really gets that tightening of that anterior lamella to get that area flattened out. And then if you combine that as an adjunct with fat transfer in that region, just micro fat transfer right in that tear trough and disrupt the orbicular retaining ligament just enough, you get this beautiful blending there. I love it near the jowls. Like I said, and with buccal fat pad, a lot of people are like, oh, if you remove my buccal fat pad, I'm going to deflate. So I tell them, I used to, before this device, tell them we can fill it back up again if you start aging. That's not a problem. We have that technology, filler or fat. Now I can tell them at the same time, we'll deposit collagen in your collagen bank right there and get you a little tight so that you don't even have to worry, and we'll keep hitting it with that until you're ready for surgical intervention. And Sheila's right. If you have this already open for the face and you're doing the neck, unless someone has a really long, really big neck and it's inefficient, this is actually, I feel like, more powerful for the neck too. And because it's an 18 gauge, you can kind of go in different regions of the neck, and almost I do some cross. I don't know if this is recommended by you guys, but I do cross swipes. So I'm basically causing a crosshatch waffling effect and stacking once the heat numbers have gone down, stacking treatments.
I do the same thing.
Yeah. No, I do the same thing. I agree. I agree. I use it in all areas. I've actually used the Iviva, which is the the vaginal rejuvenation equivalent of this technology with some safety features with really good results actually for labiaplasty as well. So here's the Morpheus that we talked about, and this just shows collagen thickening and elastin reorganization. Here you can see collagen growth, and just it goes through some patients. Here you can see this is actually a post facelift patient from Dallas when I was there, and she's really bothered by this submental laxity. So in our hands, we kind of use it in 3 groups of patients. The ones who are not candidates for surgery but want something done, the ones who may be candidates for surgery and are willing to take a 30% improvement, more people like this post-surgery. Another example here, and another example here. So to me, this is like the ideal candidate. You have some. Sorry, go ahead.
Sorry, Erez. Can you go back that one patient, the one before this? So between the left and right, she had no surgical intervention?
Right. So she had Accutite submentally and Morpheus.
Wow. And how much post-treatment is that?
That's probably 8 months, 9 months, something like that.
Okay.
Yeah, and I found a lot also, after facelifts, and I don't know if it's, me just sucking or whatever, but I do see a little bit of laxity that does come back a little bit right here a year out from facelifts. And so that's why, I've sort of brought this into the protocol, and I tell them we may need to do a smaller, maintenance procedure or a few Morpheus after the facelift just to, tighten up that skin. It's interesting. I just came back from Utah, a couple months ago at the ABAM meeting, and what the surgeons were doing in Brazil is actually, sewing the skin down onto, underneath with external sutures, almost like a net, to try to prevent that from occurring. And I think this is just a lot more elegant.
Yeah, well, the nice thing for patients like this, for example, even today, I had a patient that had a facelift by another plastic surgeon in town. The result was fine, but she has a little laxity here and there, and she's really upset because she paid all this money and the recovery and everything. And at least I feel like if I offer her an Accutite, it's minimally invasive. I'm not taking her back to the OR. The cost is, not a facelift cost. It's reasonable. So I think it's a good solution for revisions too.
I do too.
To me, this is the ideal candidate. Just like you guys were saying, there's fat there. You can remove it with lipo and then do a face tight. This actually was, she didn't want lipo. This was a direct face tight with Morpheus. So there is definitely
so good with lipo. Yeah. I would have convinced her for lipo. You should have called me. I would have.
I know, me
lipo,
too. You want to etch out that jawline.
I almost would offer the lipo for like almost nothing just to get it. But yeah, she looks like she has great dermis. That's why I feel like if the lipo was just a little bit of lipo, oh my gosh, she would be great. But especially she looks good. That's pretty powerful.
Yeah, especially African American patients, because their dermis is thicker, so you can apply more energy and get more contraction. I agree 1,000%. This is actually from Paolo Ravati in Italy. So we actually did a study on about 230 patients from Dallas and Italy and New York, and basically showed, looking at the Baker face neck classification, an improvement of about a point. And then we also looked at it in older and younger patients, and they both had a similar improvement. Now looking at the body areas, these are patients with radiofrequency assisted liposuction. This is an example, let's say, of an African American case. I made the access points here very central, which I probably would change now because it's just hard ergonomically. But when do you typically offer this to all lipo patients, or are you more selective about it, or how do you guys approach body areas?
I basically look and see if I think that they have a risk for having skin laxity afterwards. Usually the lower flanks I found don't need it. that skin tends to retract nicely and usually doesn't need, the extra heat. Upper back, upper flanks, I will use it. Upper abdomen, especially, I will use it. Lower abdomen, I'll use it if they have that little zone of adhesion between the pubis and the umbilicus. And I know that if I just lipo them, they're just going to have an apron-like effect. So those are usually places on the body. When it comes to knees, I'll use it above the knees for those tennis ladies who have that bit of crepe. Medial thigh, I will almost exclusively use Body Tight. Medial thigh and arms, I tend to use Body Tight only because I don't want to take away one problem and give them another, meaning I don't want to deflate the area and then leave them with drapery. So lateral thigh, typically I found you don't need it either. Similar skin to the lower flanks, and I find that that retracts nicely with just plain liposuction. And that's pretty much it.
Yeah, I mean, she covered pretty much the whole body, so there's not more to say, but in general though, like somebody like this, I probably wouldn't offer it because her dermis looks like it's thick. And I feel like with cross tunneling and doing liposuction, their power assistance there, I could probably get contracture without it. But I think the areas I tend to do in conjunction, because it does add length of time. And if you're under general anesthesia, there ends up being a cost benefit ratio to this if you're doing it everywhere. So I do it in areas, the most common ones at the same time, in patients that I think might have a little bit more laxity than I like. Post lipo, upper abdomen, medial thigh, knees, and arms. Those are the most common areas I would do in conjunction. And with fat transfer to buttock, I'll actually go right across the entire banana roll area and inferior ligament of the buttock crease, get a lot of that collagen deposited, then I'll go and do some fat transfer and disrupt those ligaments and try to get a buttock lift out of it, a true lift, if you will.
Yeah, that banana roll area with Body Tight is a miracle. That was like one of the first areas I treated, and it was a patient who had just one, butt cheek that was lower than the other significantly, to the point where she wouldn't wear workout clothes or white jeans. And I was able to actually lift, her buttock there and recreate and reset her buttock crease. It was insane. I told her, I read her Miranda rights, and I was like, this is probably not going to work, blah, blah, blah. But it was amazing, and she just was thrilled.
Yeah, I agree with you guys. I think there are definitely body areas that are better than others. I agree. I think arms for us are consistently good. I pretty much offer radiofrequency assisted lipo to almost everybody except for the ones that I think are a total slam dunk. And I tell them, your skin will contract on its own, but this is kind of supercharging it. And most people, and I also agree with Ash. I mean, there's definitely a cost benefit ratio. I mean, you definitely want to hit target areas, because if you don't, then you're probably, it's better to kind of hit target areas thoroughly than try to apply it broadly and kind of miss the mark, as far as being thorough with it. So these are just some examples: gynecomastia, areas that you can't excise. This is just like you were saying, Sheila, like the tennis player that works out all the time, they can't fix this. Or the arm case, people are really bothered by this. I'm sure in Los Angeles. And what are you going to do? Doing a brachioplasty seems like overkill in those cases.
And they have sun damage to boot, so they have like this thin, leathery skin that's just been burned off by the sun for years, and it's not elastic at all. But they're fit and do yoga and Pilates.
Right. Do you guys do high def body contouring a lot?
Of course.
I don't. I'll do medium def, or just lower the amount of fat in general, usually with Body Tight, to the point that it allows their own muscles to show through.
I think this is great for a high def adjunct. I mean, a lot of people, there's a whole debate about Vaser and this and that, and I think it's important to distinguish the two. Vaser and Body Tight, completely two. I mean, you're both applying heat a little bit. There's a heat factor, but the area that's affected and the target and the overall result is completely different between the two. So I actually was using Vaser in residency back in 2005 and 6, and it was same technology as it is now pretty much. So I just bought it again, I would use that for secondary cases where the fat's fibrous, gynecomastia. That's more assisting you to remove the fat. Whereas this, in high definition, in the right thickness of dermis, can actually get you tightening in certain areas where those negative spaces that Hoyos refers to, like those lateral areas, like in this patient where the costovertebral angle meets the semilunaris. If you're hesitant that it'll stick in that patient, then you can just kind of get yourself an insurance policy, build up some collagen, do adjunctive simultaneous body tight there at the same time.
Right. Yeah, I don't do too much high def myself, but this is from doctors Chris Chia and Spiro Theodoro in New York, that you guys know. And so they use it a lot in target areas, just like you're saying, in target areas to really optimize their results. And it's pretty impressive what you can do with it.
Yeah.
This is actually a paper from them. It's a great article for arms, actually. And just to show you guys some results here. So here you can see the near infrared thermal image. Now this is a patient who's really a brachioplasty candidate, I would say, by most accounts. Ash, you may remember her. She's one of the nurses in Dallas, actually.
Oh,
But,
I think I know who that is.
Yeah, but you know, this is a patient that she doesn't want an incision across the arm, and you know, to me, this is at least a 30% improvement, and she's thrilled. You know, under local hour and a half. So I agree. I think arms are good.
I have to just say, you know,
Yeah.
even the minimal incision one, you know, they raise their arms up in the air and it always widens in even the best of hands. Arm lifts are just, I think they should be reserved for someone who really, really psychologically just is okay with that scar and understands it. But if you can bridge somebody to not need it and assist liposuction with this technology, I think that's a huge leap in our outcomes.
Yeah, I totally agree. I think, you know, arms are a tough sell with the length of the incision. And, you know, Jacob Unger, who you guys may know, is working a lot on breast and, you know, taking care of those, you know, grade 2 ptosis patients and trying to avoid breast lift incisions as well. And he's actually publishing his data with pretty impressive results using the Body Tight, Face Tight platform.
Nice.
Well, I just wanted to thank you guys so much for taking the time. I think we kind of, you know, did a whirlwind tour of Morpheus, AccuTight, Face Tight, Body Tight, and appreciate your thoughts. And it's a pleasure to have the chat.